Okay, so this patient has chronic liver disease. And I want you, and they were on the transplant list. So they were, pre-transplant workup.
Okay.
And I want you to tell me if you see anything interesting or unusual.
I don't like the looks of the posterior aspect of the right lobe of the liver.
Yep.
Okay. And let's just say there was some treatment change there, all post-treatment change. Good. Excellent.
Post-treatment change.
Yes.
Okay.
So other findings, and focus on the vessels.
Yeah, there's tons of collaterals, right?
A little bit, yeah, like by the anterior, like segment 2, like there's a bunch of little vessels right there, but maybe there. Or
Okay.
like posterior segment 2.
Like here?
Yeah.
Okay, that's not exactly the area I want you to focus on.
Extrahepatic vessels though, like there's more varices than we ever see.
Extra or intra.
Like is there
Okay, so
type of varices you might see if there is an IVC occlusion or something, maybe like a lot of shunting.
Yeah, like where's the left hepatic vein? So just right, middle, left. I see the right. Where's the middle and the left?
Okay, so you guys both got it. You guys both got it. This is a really tricky case, and I know it's hard to like just have me scrolling. But one thing that Steve noticed is like we've got a lot of extrahepatic collaterals that are weird. They're not like the normal varices. These are paravertebral and these like intercostal varices that are going into these very large azygous veins, which are unusual. And he said it's the type of thing you see if there's an IVC occlusion. And then Nelly said, where are the left, middle, and right hepatic veins? And if you'll notice, they don't come together to a normal IVC.
Yeah, you're missing the upper intrahepatic segment of the IVC.
Is this the Abernathy malformation?
No, Abernathy is a malformation of the portal vein. This is basically kind of a Chiari spectrum, where you don't have the upper part of the intrahepatic IVC. Yeah. And so I'll just show it to you again. Okay, so here we've got the IVC. It comes up, normally goes into the liver, but instead we've got this other like weird vessel here. This is actually an intrahepatic collateral vessel that is like, see these veins here are actually forming this web of veins.
Yeah, they're not
that are now draining into the IVC through this big collateral here.
Yeah, it's bizarre course. Like the normal hepatic veins are almost like what I describe as the spokes of an umbrella, and the IVC is like the center pole.
Right. So you don't see that normal bunny appearance. We don't see the spokes. We see it actually draining through intrahepatic collaterals to the IVC. And then we also see these huge, intercostal collaterals going into the azygous. So just to sort of cut to the chase with this particular case, we didn't really recognize this up front. We just kind of said like, okay,
there's collaterals.
Yeah, we just said there's a bunch of varices, not really recognizing that these azygous ones are pretty atypical for varices, and that there was no true IVC here. So patient ended up going for a transplant, and when they tried to go do the transplant, they were like, there is no IVC for us to sew to. So they ended up having to call in vascular surgery, create a de novo IVC to sew to, like the IVC kind of comes back here. So there was a snippet of it going into the right atrium. So the vascular surgery had to reconstruct like an IVC connection between this guy and then like this infrahepatic IVC. And then they plugged the liver transplant into that. So then going forward, post.
You have the chrono.
Yeah.
They would have liked to have known that.
Yes. So that's why I'm showing the case, just to sort of remind us, because even if they don't come with the indication of Chiari, these are signs that like something is different here. I don't think the chronal helps that much because we're now in like a later phase, so you don't see the collaterals as well, but you can see that there's a lot of weird vasculature here.
You think they would have thought, too much trouble and not bothered with the transplant, or just been better prepared?
I don't know. It's interesting. That's a good question. But basically they just came back to us afterwards and were like, did you guys see this? Did you know this? Okay. So now I just want to show you. So post-transplant, this is now post-transplant. So post-transplant, you can see that there's this little conduit here. And you can see actually they now have effusions and refractory ascites, and they've got a congested appearance of their liver. So then they said like, okay, like, you know, we want to see if our shunt is working well because we had to create the shunt on the table, blah, blah, blah. And so can you know, like, why is there refractory ascites? We're worried about the shunt. Whereas they were sort of well compensated before. And then I'm just going to jump to their angio images. And you can see on angio, when they went, and injected the IVC, nothing went above this level here. So they're still really shunting through all of these intercostal varices into the systemic circulation. Does that make sense? But pre-transplant, they were sort of well compensated because all of those collaterals were well built. And post-transplant, they ended up with refractory ascites because they were trying to shunt it through. And actually, probably there was now more flow into this new transplanted liver because it's low resistance. And it was not able to handle it through that, that suprahepatic IVC shunt.
What did they do to correct it?
I don't know. It's still ongoing. So yeah. I presume they might try to go they didn't at the time of this, they couldn't even get a catheter up through like connecting to the suprahepatic to like into the heart. So they couldn't try to like dilate anything. So I thought it was just a really interesting case.
Great case.
Okay.
This is a pre-treatment scan.
Pre-treatment for
gastric cancer.
Yes.
I feel like there's a circumferential thickening of the antrum and
Yep. So I'll show you the coronal on that. Yeah.
And it's a nice gastric protocol with like nice distension of the stomach.
Either that or it's gastric outlet obstruction.
Yeah.
I think probably the latter.
I know, actually, I was gonna say because we use Volumen, but this looks like a bunch of like food and stuff.
Right? Look at all the debris. It's not a so I think it was probably that. This was multiple years ago, the pre-treatment. And then the patient had chemotherapy, radiation.
Wait,
and
Nelly, I have a question
Yes.
based on that original scan. Were there any lymph nodes around it? Because usually they spread quickly to like perigastric lymph nodes, and then you have to look for lymph nodes that are out of the local nodal stations. But
yeah, we had this conversation many years ago.
I see a node here
about
yes, M1
the gastric nodes and how you could miss them or mess up on them.
Right, and so that node I think is a GDA node, Nelly, which I think is still it's still a local node
or regional.
And there's small nodes there that I see. And then there's, I don't know, this looks like a node.
Oh yeah, so that's like a celiac
hepatic space.
Yeah, celiac
right
axis.
there. The big one.
Yep.
That's a good one.
Yep. So those are all still local regional.
Yeah, right there. So my teaching point is something else, but I have to. So anyways, patient got
the debate between omental or interperitoneal carcinomatosis versus sort of perigastric nodes, right? Didn't you bring that up before, Aarti?
Oh, staging. Or I don't know if it was Aarti, but
yeah. So if they're like, if it's spreading into the omental space, but directly, then we don't call that omental spread. It could just be, so there's like 20 or so nodal stations that are along the stomach that are all the regional ones, but the more distal ones are like if you get retroperitoneal nodes below the renal veins, diaphragmatic nodes, retrocrural nodes. So anything a little bit further, and then the peritoneal disease should not be like direct spread into the omentum. It should be like separate nodule.
Which can be a tough call though.
Yeah, but if in doubt, just maybe like
say it can be direct extension,
and they'll many of them they'll do a laparoscopic staging, and about 50% of those will actually have peritoneal disease on staging, I think. Okay, go ahead, Nelly.
So after the chemo-radiation, patient had radiation-induced gastritis, pretty significant. You can see here, and patient was followed and scoped, and then patient. I forget what the indication for the MRI was, but the MRI was done. And here is I wanted to show a nice MR PET correlate for finding that I think is only really best seen by MRI and subsequently by PET. So this was the T2. And I think in this case, the diffusion is
Visual or
really
recurrent
helpful.
disease in the stomach.
Yes, yes, right. So we saw the pre-treatment, the disease in the antrum, and you see it's restricting right there. If you look at the CT, do I have the CT? None of that is apparent. Here I do have the CT.
EG's not good at that.
No, it's not. It's not. And so, oh, here that was the CT. So the patient had radiation-induced gastritis, but here maybe the density is a little bit more iso rather than hypo from the
You can't
radiation
tell the difference
gastritis, but
between
it's a hard call.
wall and the cancerous wall.
Yes, but if you look at the diffusion, the ADC, right, it's pretty convincing right there. That area, and patient subsequently had a PET that also has a corresponding PET uptake in that same
Right.
exact area where the diffusion restriction was, and proven to be recurrence.
Wait, why
So
are you
the
saying recurrence versus like it just wasn't fully
viable.
treated?
Yeah, or
viable.
sorry, yeah,
Okay.
local. I mean, tumor progression. I don't know. Residual disease, is that the right word?
Just
Because
Yeah, like-
patient was
Side
surveyed.
sort of thing, residual versus recurrence, because
Correct.
the time interval between scans,
Yeah.
like it looked like it was totally gone, then you probably call it recurrent.
Yeah, patient was, it was like I said, the initial treatment was several years prior, the post-treatment exams that we're looking at. So it's a great illustration of how diffusion on MRI can be really, really effective.
Yeah, diffusion is a good test.
Okay, I have a question though. If they thought it had responded and we said that there was local regional disease, the next treatment would have been a surgery. So why hadn't this patient gotten surgery?
Yeah, why not surgery? Maybe Nelly doesn't.
Oh, so sorry, I don't I forget I forget how surgery versus chemo-radiation was chosen. I don't know if it was patient factors or
Okay,
I don't know
just wanted to be clear,
exact
because if there
history.
wasn't peritoneal disease, then the goal is chemo and then surgery.
Right.
Yeah. So
Yeah.
yeah, no, you're right. Sorry, I didn't really like dig that deep into the rationale that led to that treatment pathway. And patient was like followed, like the patient had like work up elsewhere and then came to us. So I don't know if the primary treatment was done with us or at the other facility. So I don't know the answer. The treatment post-treated studies that I read though, was just showing some of the workup leading to the diagnosis of recurrent disease.
Cool. And just to be controversial, you said you saw it on diffusion and on PET, so PET MR would have been the best one-stop shop.
Yes, it was separated by time frame, and I forget exactly why, but it wasn't done like the same day or anything like that. It was like actually separated by several months.
Okay. Just trying to make a point.
You said PET MRI?
We do have PET MR. It's a little bit on hold at the moment because
we do PET MR primarily for pancreas. It's gastric cancer is not one of the common indications for PET MR in our facility. So I don't know if PET MR is the study of choice in general for gastric cancer or not.
But you do it for pancreatic adenocarcinoma?
On a regular basis, yes.
We do, and then we do like PSMA PET MR for
yes.
Yeah, what about dotatate?
And dotatate, yep.
Yep, that's the other indication
for
for
neuroendocrine.
Yep.
Okay.
This is a case that a colleague brought to me and said, there's something funny going on with this liver. And it wasn't done for liver. It was actually done. Well, of course, I'm getting a call. Hang on. Stop the recording. You can read. Okay, so it's basically done as a, believe it or not, a CT enterography. And I just noticed that you could probably tell that without even me telling you if you saw something like funny about this image here, because we did it.
The patient's
supine. Yeah, exactly. Which it doesn't have to be. I don't know why we do that sometimes, but
well, apparently, like that's the standard for CT urography. Apparently, it releases.
It can be because it squishes out the bowel a little bit better, but
right, and also apparently it releases the ureter, so there's not as much like compression on them, so they can maybe like excrete more.
All right. But anyway, they said, hey, there's something funny about this liver, and I looked at it. And I said, yeah, there is something funny about that liver, and I I had ideas about it, but I wasn't sure of it until I looked in the chart and the page.
HHT.
Yeah, exactly.
So there's all those little vascular shunts, but then
Yeah.
the hepatic artery also looks prominent, which is a sign of HHT.
Yeah, it's a
What looks prominent?
The hepatic artery.
Oh,
This one
yes.
is not the most
then-
dramatic, but sometimes they get really big, hypertrophied, because they're feeding all those vascular shunts.
And
Yeah.
they also get dysplasia, angiodysplasia with HHT. So then I had a case where the segmental hepatic artery, very serpiginous looking and,
yeah.
kind of abnormal.
So I can't stump you guys, but anyway, this is kind of, if you Google HHT images of liver, a lot of them look a lot like this. Some of them even worse, like with bigger stuff than the biggest here, which is probably this guy.
Yep. Okay, so focus on the left upper quadrant.
Okay. There's like a eventration of the left hemidiaphragm.
Good.
There's all
You-
this soft tissue stuff.
Yeah, there's like something between is at the top of the spleen, or I don't know, the backside
Between
of
the
the
stomach and the
Yeah.
spleen, yeah. And there's like perisplenic hyperdense
Did
or
it- yeah.
hypodense stuff.
Reminds me of a case I had this morning, in fact, where we were trying to determine between a pancreatic tail mass versus a colonic mass, and it presented in colonic obstruction. You
Okay,
don't
good.
obstruction
Excellent. So this one is in this like space. So I would say it's separate from the pancreas down
Yeah.
here. It is touching the stomach. It is
Maybe it's a
briefly
gastric
touching
primary.
the colon, and then there is some blood and hyperdense stuff around the spleen, but probably not from the spleen. So what do you guys think?
Like a bleeding gist, maybe.
Good. Awesome. So, okay, just I'll show you an MRI, but just like, to point out, there are really different aspects to this thing here. So this guy looks
Yeah,
more
it's
like
heterogeneous.
and whorled.
Hypo. Yeah.
And then this guy looks kind of heterogeneous. Like both of these kind of look like they could be blood.
But then there's like this dense stuff right
Then
there.
this dense
That
stuff
mass,
could
yeah.
look like maybe it's a mass, like an enhancing mass.
That thing's a
Okay.
lot. Yeah.
And then you're like, is it a gist? Like, is it a gist with like the tiniest little stalk here? Like, have you ever seen a gist look like that? Like so exophytic. But
They
anyway,
can be exophytic though. I mean,
they
but
can
it's
definitely be
both.
exophytic.
Yeah.
Okay, so I'm going to show you the MR. So we're like, it looks like blood. It looks like a mass. Let's get an MR. So, okay, this is the pre-contrast. So you can see that the parts that we thought were blood have like T1 hyperintensity with that peripheral kind of rim. So definitely hematomas. And then this was like the dense part. And then I'll just go to the delayed, and you can see that that dense part is densely enhancing, and it does have this interface with the stomach. So again, it looks like a weird shape, but the only thing we could think of like for an exophytic gastric mass that's bleeding is like a gist. And this was resected and was a gist.
Huh.
So yeah, it was a rare ruptured hemorrhagic gist. As you guys know, gists have like a spectrum of malignancy, and you can use the Memorial Sloan Kettering nomogram to say what risk of recurrence there is. It's based on size, origin of location, and mitotic index. So they plugged all of that in for this guy, and it had a low mitotic index. And so this was actually a low risk gist. They said it has about a 3.6% chance of recurrence. However, I want to talk about hemorrhagic gist. So I just like looked up some papers about hemorrhagic.
Not real common, right?
It's not very common, but but you know what is common is when you Google or when you PubMed hemorrhagic gist, most of what they're talking about is when the gist has eroded through the mucosa and is causing GI bleeding.
GI hemorrhage, sure.
And that is actually very common.
They ulcerate. That's reasonably common.
Exactly.
Yeah.
So it's not uncommon for like a patient to show up with GI bleeding or anemia, and it's because of a gist. So that's not uncommon, but for it to actually rupture, so it has kind of a capsule to it. So usually does not rupture beyond that capsule. So this is a rare one that like ruptured kind of into the peritoneal cavity. So 2 points I want to make. One is that situation is pretty rare as opposed to the GI bleeding situation. And the other is that if it has ruptured into the peritoneal cavity, unfortunately, even though this is a low risk gist, this now has a much higher rate of recurrence because tumor cells have shed into the peritoneal cavity. So that's it. Any other thoughts, or is it really interesting? I don't know, just a rare kind of ruptured gist.
Yeah, we had a hemorrhagic liver tumor this morning, tumor board that was, I do this,
HCC or versus adenoma?
yeah, exactly. It was probably HCC, I thought, but it could have been adenoma. And it presented with bleeding, you know.
Yeah. And in like same thing with HCC, if it ruptures, then there's going to be a higher rate of recurrence and peritoneal disease.
So this is a patient with left renal cystic mass. What do you think?
It looks like it's herniating into the renal
traction.
pelvis. So I'm thinking multilocular cystic nephroma, which is now called in the MEST spectrum.
MEST, yeah.
That's benign, right? Like totally benign, isn't it?
Yeah, although
yeah, they're both benign, but they're Bosniak 3, and so like
that they end up as Bosniak 3s, and so you have to have a high index of suspicion for MEST for it not to end up in a urologist bucket.
So have we figured out a way to separate a MEST versus a Bosniak 3? So I'll say that this was a year prior to the image that you just
Natural
saw.
history is a good part, but of course the Bosniak 3s are very indolent and can, you know, change little in time as well. And yet, if you hand them to a pathologist, a fraction are going to end up with renal carcinoma in the wall somewhere, and those nodules and thickening.
Right. So 50% of Bosniak 3s are supposed to be cystic RCC. So it's kind of like, do you want, like, what you're placing bets here? But based on the appearance, I would place my bet on an MCN / MEST spectrum and benign. But, you know, sometimes younger patients just want to get it out. Older patients, you could watch it.
Yeah, we're moving to a greater propensity to surveillance for these types of things. The threes are sort of merging with the 2Fs.
The patient was much older, so
yeah, that's more argument, especially if there's comorbidities, more argument for surveillance. But this is later. Oh my gosh, what's going on now?
Yeah, what's going on now? So I'll say that the patient did not get the follow-up that was recommended for several years.
Here.
And then presented with hematuria.
Yeah, well now it looks like
now there's like huge solid components.
Carcinoma, yeah, with metastatic adenopathy.
So yes, so that area where there was a cystic mass now has a soft tissue component invading into the collecting system, the renal sinus fat. There's necrotic nodes in the retroperitoneum, and I forget if there's renal vein invasion or not. There's probably, I mean, if it's a sinus fat invasion and it becomes T3, so either renal vein or sinus fat invasion, it makes it a T3.
You know, why surveillance is important as it is, because this is
what actually there's a tumor right there's tumor in vein right there.
Really, this still, like, if I saw this de novo, I would still put urothelial in the differential.
Yes,
means
that exactly right.
Was like true and unrelated. Where
exactly
right. This looks like a UCC, right? It's
that look like GCCs lately. Like the last one of the cases in my last 2 GU tumor boards was one where I would have probably said incorrectly that I favor an infiltrative TCC or a renal TCC over a RCC, and it was an RCC.
Okay, now what was this?
So this was RCC. This was clear cell RCC. It has a TCC appearance, as already alluded to. It has a very reniform shape. Even the enhancement, right? It's kind of homogeneous, a little bit more homogeneous than typical clear cell RCC. And it doesn't like hyper enhance and wash out like classic clear cell. But this was biopsy proven clear cell RCC. So there's several points that I took away from this. Number one, like I have this, my position right now on Bosniak 2F is that we follow them too much and too aggressively. And that's for 2F, not 3s. This was a Bosniak 3 and 4. But even then, right? Like it's, but then you have these kinds of cases, right, where you're just like, you know, just like reconsider your thought. I'll share that we don't really have any long-term outcomes data on the effectiveness of these surveillance protocols and recommendations that are endorsed, you know, by various guidelines. But this is one of those cases that you know, kind of forces you to think again.
Honestly, that's a great multi-center mission for some of these DFPs.
Mm.
Take the surveillance recommendations and just say we're going to start, compiling data to figure out what's meaningful, what's worth it.
Yeah. One of the research projects that I'm going to start right soon, shortly, is to look at Bosniak 2F 3s and 4s, and then compare the group that underwent treatment and the group that didn't, like that were actively surveyed, and see if there's any disease-free progression, if there's differences in the Kaplan-Meier curve. But we'll see.
Cool. So like Steve said, like we're doing much more active surveillance, and this is in the spectrum. We're talking about like cystic renal masses, but also small solid renal masses. Our group is starting to use the CCLS, the clear cell likelihood score, to try to say, like, do we think this could be a papillary or an oncocytic neoplasm or even a FAP4 AML, and therefore like more active surveillance.
Yeah,
but it has to be active surveillance. It can't be like come back in 5 years and
exactly. I mean, it's
because the bad actors will start moving, and then you can act on them much more quickly.
For sure.
There's a lot of surveillance, and so I'm gonna go off on a little tangent on another GU cancer, bladder cancer. There was a grand rounds recently given by our GU oncologist about bladder cancer and how the treatment paradigm is going to significantly change very soon. He shared some recent data that came out showing these newer immunotherapies. They can now do bladder preserving therapies for patients with muscle invasive disease.
Oh, wow.
Without impacting outcomes compared to cystectomy arm. It was crazy. It was like, I couldn't believe it. Using this, he calls it EVP protocol, and for tubemab vedotin plus pembro.
Cool. Yeah, I guess it's just like surgery is really morbid, so that shouldn't be the, like we should start questioning that more and more.
So I think imaging is going to play like, a significant role in active surveilling a lot of GU cancers. Interestingly,
more work for us.
Yeah. More interesting for that bladder preserving clinical trial, they didn't use imaging for staging. It was all cystoscopy based staging, which is I thought really fascinating.
There was a survey recently in the abdominal section heads group about who's doing the VRADs for
right, exactly, like the bladder staging through MR.
There's really very few places.
We're starting to do them. Our urologist likes them a lot.
Okay.
So that's what we're doing for pelvic MR.
And you guys will prove or disprove the utility of it, but a lot of places jumped on board yet.
Yeah, well, based on the bladder preserving therapies that's emerging, and the data is pretty robust. I bet bladder MR will become one of the mainstay modality for staging. That's my hypothesis.
It's just a little time intensive because you have to like make sure the bladder is like fully distended, but not so distended that the patient's like jumping off the table.
Right.
And then the yield for like very small tumors that you would see on cystoscopy is still lower from what I've read. So that's just like kind of where, but maybe that's where like Nelly, like these immunotherapies will like put those guys at bay. And then like you will see the definitely muscle invasive ones and you'll be able to monitor them on MR.
Yeah, it'll be like rectal cancer, right? Like right now, for example, we're doing chemo-radiation for T3 disease. We're not doing surgery anymore. And so now MR
for certain patients,
yes,
for T3 disease. Before it was neoadjuvant followed by LAR or whatever.
But I think what I think is different about rectal cancer versus bladder is that bladder is like this multifocal chronic
field effect.
Like situation where like multiple tumors kind of come up, like little superficial tumors, and that you have to keep. That's why they keep going for cystoscopy. Whereas rectal cancer is like usually one lesion. It spreads locally. You treat it. You can monitor that. So it's a little bit of a different, baseline disease.
True, but if this EVP protocol does become a standard of care, then it'll be similar in rectal cancer in that you have essentially a curative therapy, then you have to survey them, right, with something. And with rectal, we're using pelvic MR for all of these like non-operative
No,
You know,
Nelly, we're not just using pelvic MR. They're also getting colonoscopy and like proctoscopy.
endoscopy.
Yes.
Yes, yes, for
So,
sure.
so
But
like that's where I think cystoscopy will still be a part of bladder cancer screening.
yeah, I don't think it's going to replace cystoscopy. I think it's going to augment. Right now there's no role for bladder MR in the current workflow. And like again, like potential future DFP efforts, I think could really look into the role of, because it's very limited with the way we do staging with cystoscopy, right? You just see mucosal, like really superficial stuff. I mean, of
But
course
you can also
you can
treat.
deep. Yes, you can also treat.
I'm not making the case for cystoscopy. I'm just
No, I mean,
Trying to
I'm not
navigate it.
saying replacing cystoscopy. I'm saying to complement cystoscopy, right? You're seeing a holistic view with MR that you don't get with cystoscopy.
Yeah, especially the muscle invasive stuff. Okay, I'm going to stop for a second. Okay, this is a kind of a complex case. I'm going to direct you guys to where I want you to look, but let's say this. Okay, actually, let me go back. This person.
There's a history here.
Yeah. So a lot of history, but basically they've had a colectomy, they've had multiple surgeries, they've had pelvic collections that we thought were like benign collections, but that basically were causing chronic hydronephrosis of the right kidney. And you can see that the kidney is a little bit, this was a while ago. They've got basically chronic bilateral ureteral stents. These are not Nelly's resorbable stents, and that is an interesting point it maybe would make later. But anyway, they've got chronic stents. So now we fast forward 2 years, and they had a florid UTI, and they underwent stent replacement. And after stent replacement, they had massive hematuria.
Yeah.
So you can see that there's a lot of blood in the bladder.
Bladder.
The stent is still in place. Take some.
It's not really heading the right direction.
Yeah, let's ignore. I'm gonna just ignore this perinephric hematoma for a little bit. That was because they were basically in shock at this point, very like hypercoagulable, like bleeding all over the place. So when they went to put in a nephrostomy tube, they bled. But what I want to draw your attention to is this stent. So if you follow the stent down,
There's like active bleeding.
there's active bleeding in the stent. So what would you call this?
There's a fistula between the little vessel posterior and the ureter.
Exactly. So this is, I didn't even know there was an acronym for this, but this is an AUF, arterio-ureteral fistula.
Woo.
And this is rare, but not as rare as you would think. And I'm going to show you guys a cool paper that I found. But basically, I'll explain my understanding of it at this point, and then I'll show you the paper. But people who have who get these arterial ureteral fistulas, 80% of them have a chronic indwelling stent.
Yeah, it's probably like a pressure ulcer in the wall of the ureter.
Exactly. So the stent is like, and it usually happens where it crosses over this common iliac artery. Or sorry, external iliac artery. So right at that crossing point is often where it happens, or sometimes a little bit higher up. And the other significant risk factor, 70% have had some kind of radiation or cancer. So because the radiation causes normally, I guess the ureter doesn't pulsate, like doesn't really get this pressure ulcer against this pulsating artery, because the ureter can like bop around and be mobile. But if there's been radiation or some kind of fixation, surgery, oncology, etc., then it gets fixated there, and then it can cause that pressure ulcer. And usually those patients will have intermittent hematuria, where like intermittently, like little bleeds will go into the ureter. And then at one point, either like because of something or because of a stent exchange, it will open up the floodgates and they'll have massive hematuria.
Wow.
So this is just a CT angiogram example of the artery extravasating into this ureter. You can see the dilated ureter was like dilated, right? It was like the hydro was also because of fibrosis, because of that crossing area.
Sure.
And then I'm going to show you the angiogram as well. Just go to, let's see here. Okay, so here you can see they shot the angiogram and then it is extravasating into the ureter and then like basically where the ureter is obstructed. And then the treatment for this, if you see it, is a stent. And so that's what they did. They basically placed
a wall stent over the
artery. They placed a stent over the artery.
Yep.
Oops. And that's how they prevent the extravasation into the ureter. So yeah, that's what I want to show you. And then I want to show you this. This is this interesting paper I found. Okay, so this is a systemic review of 445 patients with an AUF, arterio-ureteral fistula. So even though it's rare, it's not actually as rare as like, you know, so
reasonably common.
And they basically show, they went through like articles. So some articles had multiple patients, some are like, they went through all the demographics, risk factors, etc. And this is their little paradigm, which is like they often have intermittent hematuria, but then some massive hematuria. Their risk factors are, you know, ureteral stent and radiation. And then if it's positive, you'll go to treatment where you put a stent over it. And then one more thing I wanted. Oh yeah, these are the locations. So it's frequently the common or external iliac arteries where the ureter is crossing over. And then one more thing. So these are the theorized mechanisms. So pulsation against this fixed ureter where you get a pseudoaneurysm, or like kind of like kinking and draping, and this chronic stent that's like stuck to the artery there.
Plus, I think the mechanical of the stent has got to have a potential to.
Yes, but it's especially when like there's some kind of fibrosis or radiation or some other kind of thing that causes the ureter to like also be stuck. But yes, even if you have a chronic stent, like that can just cause like it to be very fixed. Yeah, so that was it.
Well, I'm not sure if I've ever seen that before, at least before now.
I've seen it once before. And so when we saw this one, I was like, oh, this is so rare. And then I'm like, oh, it turns out it's not as rare as we think. And it has this very classic kind of like intermittent hematuria and then massive hematuria and then this classic history. And so, yeah, it's just something to know about.
With
Hold on. Okay, go.
Okay. This is the patient with hematuria and had a standard CTU. So there's, you know, on the nephrographic phase, we see multifocal papillary, bladder lesions. And the upper tracts were clear, and then the urographic phase, you know, we see the filling defects there, corresponding to site. So, I mean, this is the I wanted to reiterate how valuable the nephrographic phase is. This is a little early nephrographic, but to look for ureteral enhancement. And I find that it's very helpful for the bladder, for CIS, for example, right? Like some of these flat lesions, for example, I see them best on the nephrographic phase, the venous phase. And
sorry, I completely agree. And I actually feel like this is a better phase than the excretory phase, which annoys me. Half the time it's like layering contrast. And like,
there's papers that say that basically the nephrographic or venous phase is as good or superior to any excretory phase, except, and that's not for urothelial cancer, but it's, well, it can be, but the morphology of the intrarenal collecting structures, if it's just a hematuria case, not really a urothelial cancer case, but if it's just a hematuria case, you do best with the morphology of the intrarenal collecting structures on the excretory phase. You can't really do that without a good excretory phase. But for the bladder,
oh, you mean like looking at like the papillae and like something that like some tiny
papillary necrosis is actually a reasonably common cause of hematuria, and it's under reported, underappreciated, and reasonably common.
Yeah, I think we need the urographic phase. I don't know if venous is better, but I think venous is extremely complementary and needs to be part of the. For example, we have a split bolus protocol that I don't like.
We just actually switched from split bolus to a triphase to like basically nephrographic and excretory.
Yes, I think the venous is essential, and there's been papers looking specifically at UCC, not the congenital or these other causes of hematuria, but UCC. And I
Yes,
think a third or a little bit more than a third are only detected on venous phase.
that's correct. Yep.
And then of course others are detected on urographic phase. So and the types of lesions seen on venous is different from the lesions seen on urographic phase. So it has a complementary role. And I think like if we wanted to reduce radiation exposure, maybe perhaps dual energy could be, something so that we could just create a virtual non-con. But I do like having venous phase on my urogram for this reason.
Definitely.
Agree. One thing you can do that, I don't know if you're monitoring it or if you're creating the protocol for the split bolus or for the extratorrhea phase, is just have them do a log roll, because that'll take out that like layering contrast thing. Because I've seen tumors that you would have missed if like on the layering part, and then you make them do a log roll and then you see the tumor. So
we do the split bolus usually just on young patients, right? And in these patient population, risk of UCC is much lower compared to the older population. So, I mean, it is a different population that most of the split bolus occur in.
right, we do it for hematuria. But there's micro and gross. Micro has low yield because that could be like a few red blood cells. Gross, higher yield. But I still think like if you're gonna do it and the patient has gross hematuria, we should try to optimize it. But yeah, I have
Agree. Awesome. Well, thank you so much, all. It's great learning from you.
That was great stuff, you guys.
Good to see you, Steve. Bye.
Have a great rest of your day.
Hear your
Bye.
voices.
What'd you say?
Have a great day, guys.
To hear
Bye.
your voices.
You too. Bye.
Bye.